Welcome to another episode of Watson Clinic Health Talk. Today, we're talking about bladder health, kidney stones, BPH, UTIs, incontinence, bladder cancer, and much more. Joining us in this discussion is urology specialist Dr. Genesis Nieves. Dr. Nieves accepts appointments from our Watson Clinic main location at 1600 Lakeland Hills Boulevard in Lakeland. You can schedule yours by calling 863-680-7300 or by visiting watsonclinic.com/Nieves. That's Nieves. So you just recently arrived at the clinic.
I did.
So I'd like to know a little bit about you, where you came from, what kind of schooling did you have, why did you choose urology of all specialties?
Yes. So I'm originally from Miami. I went to undergrad at University of Florida. Go Gators. I then went to medical school at University of Illinois at Chicago, and I did my urology residency training in Memphis, Tennessee at the University of Tennessee. Urology, I actually wanted to be a general surgeon and then was thinking about maybe doing plastic surgery or cardiothoracic surgery. And I did a rotation my third year of medical school, and it just happened to be urology. They just gave me that rotation. And I noticed, I was like, wow, everybody's so happy. And urology, they're just doing procedures in clinic. And it's not just the same sort of procedures in the OR. It's just a variety of things. You've got kidney stones, you've got cancer, it's just so many different things. And so I really just fell in love with urology. And I feel like every specialty kind of has its own personality. And I just felt like I just fit in there. Yeah.
Okay.
Yeah.
Awesome. How have you taken to the clinic so far in this community here?
I absolutely love it. I feel like Lakeland, the opportunity has just been such a blessing. The location is such a blessing too. I feel like it's such a family-friendly area. And I hopefully want to build my own family in the next few years. And so I think this is a perfect place to do so. And the patients have been so welcoming. They're so nice. They're so accepting of me, just coming out of residency and training. And, they still are very trusting of me and just willing to let me help them. So
it is a wonderful community and a wonderful community of patients.
Yes.
I mean, we've been here for 84 years, so you'll see a lot of people that we've treated generations of their family members.
Yes, yes.
So we're in a way a part of their family. So let me tell you, when I think of bladder health, the first thing that comes to mind, and I'm sure this is true of many people, is, you have to get up to pee a lot more frequently during the night as you get older. Not that that's happened to me, but so do you hear that a lot? And should that be considered a normal part of aging?
So yes, I hear that a lot. It's not necessarily a normal part of aging. So it can be a number of different reasons why you might be waking up at night to go to the bathroom more often. So it could just be how much fluid you're intaking right before bedtime. And that's something that could easily be corrected. There can also be, specifically in men, some prostate issues when you have enlarged prostate. Also, you can also have sleep apnea. And that actually increases your fluid excretion overnight just because of the deoxygenation to your,
Really?
yeah. And then, so that plays a role. And a lot of times when people just come in with solely the complaint that during the day they're doing fine, but at night they're having trouble, I tend to refer them for a sleep study, and they end up having sleep apnea, get their CPAP, and they're fixed.
That's interesting.
Yeah.
But that's another benefit of being at Watson Clinic, because you have all of these other specialists you're working alongside, and you can easily refer right then and there.
It is very nice. Especially coming from at least where I trained, everything was, there's a hospital, there's clinics, and there's different private, specialties all around town. And a lot of times, you might refer somebody, you don't know what really happened until you get the facts. back with their report. And here it's so easy because it's all in the same EMR.
Yeah.
And so I just immediately I know. And even when I do stuff in clinic, it's easily available to all the other physicians. So I love it. I love the
Yeah.
internal referral system and being able to have everything in just one spot.
Yeah, it's very interconnected.
Yes.
Okay, so back to urology.
Yeah.
So you talked about the scope of services that appeal to you about this specialty. Tell me a little bit about those services. What are the main services that a urologist performs?
So there's definitely, BPH, which is benign prostatic hyperplasia or enlargement of the prostate. We have recurrent UTIs all the time. I've been seeing that frequently, as well as interstitial cystitis, chronic bladder pain syndrome, kidney stones. I feel like Lakeland has so many patients with kidney stones. It's incredible. And there's also a lot of cancer that I've noticed as well. There's a lot of bladder cancer, prostate cancer, and so those are a few things. But also incontinence, overactive bladder.
Well, let's touch upon some of these. You talk about kidney stones being very common.
Yes.
What causes them?
So I would say number one is dehydration. Especially we're living in Florida, everybody's outside, it's hot all the time. So that definitely increases the risk of developing kidney stones. Your diet is huge. So the most common kidney stones you'll find are calcium oxalate. And it's kind of weird because you would think that you would want to stay away from the calcium. We actually want you to take in the adequate amount of calcium that you are supposed to have in your diet. The oxalate is the problem. The oxalate is what actually causes the stone if you have too much of it. And a few examples of some foods that might have that are nuts, spinach, which I love spinach. Yeah,
I do too, yeah.
yeah, so those are a few risk factors, but there are also some other kinds of kidney stones that could be formed. So patients that have gout, they have a higher propensity of developing uric acid stones. Sometimes you might have a metabolic derangement or certain deficiencies that you might be born with that can cause like cystine kidney stones. So there's a number of other stones as well. But the most common one I definitely see is the calcium oxalate. So.
I've heard in the past too about if you drinking too much soda can cause them, or is that a...
It can, because the sugar in the soda also dehydrates you in a way.
Okay.
And then it also doesn't help with any of the urinary symptoms because it is a bladder irritant. Any sort of carbonated drink, even carbonated water, is a bladder irritant. So
Okay. And with the kidney stones, unless it's an extreme case, is it generally a wait and see? And if it doesn't pass, then you intervene, or what? How does that work?
it depends. So if you are presenting to the emergency room and you have a kidney stone in your ureter, which is that tube connecting the kidney down to the bladder, depending on the size, so let's say that somebody comes in with a 6 millimeter stone, there's about a 40% chance that you're going to pass that stone. Usually we recommend, starting a trial of passage, which is starting Flomax, make sure that their nausea is under control, have them strain with every void, using a little strainer to see if they catch the stone, making sure that you're adequately hydrated. We say try and drink 2 liters of water or more a day. It's very hard, but that's the goal, especially if you're trying to pass a kidney stone. So there's a number of things to do, but by 3 to 4 weeks, if you have not passed your stone, whether you've been checking the strainer or we get a repeat imaging to see if you have passed the stone or not. If you haven't passed it, then I would recommend going to surgery to try and take care of that. But that's only if it's stuck in the ureter. There are times, though, that if you present to the emergency room, your kidney stone is causing a lot of backflow of the urine where it's causing obstruction. It can affect your kidney function. It could affect your infection numbers. Your pain can be intractable. If that's the case, then at that point, I would recommend an emergent stent placement, which is just a hollow tube that allows the urine to bypass that stone from the kidney down into the bladder.
Okay. Is that something that's performed outpatient in the hospital or in the office, or?
So that would be in the hospital. Okay. So that's if you're coming into the emergency room and you're really, really sick, your kidney function's coming up and everything.
Okay.
And that would definitely be an indication for a stent placement. Now, there are some patients that might have non-obstructing stones, so stones up in the kidney, that can sometimes cause a little discomfort. They don't necessarily cause that classic kidney stone pain that many women have said that, it's worse than labor pain, who have also passed kidney stones. So at that point, we can try and take care of the stone as an outpatient procedure in a controlled setting.
So tell me a little bit about BPH. This is a common condition, isn't it?
Very common. So as a man gets older, their prostate tends to enlarge. And a lot of times, you can have your prostate enlarge towards the outside, but sometimes it can enlarge towards the inside. And if that's the case, then you'll have those typical symptoms that we hear about all the time, which is the urgency, frequency, hesitancy, dribbling, straining. So that is when we would recommend either medical management with either Flomax or finasteride, something that can help either relax the prostate or shrink the prostate.
Those are effective medications?
Correct. So the Flomax, that is it relaxes the prostate. So it sort of allows that your urethra to kind of open up a little bit and help you void. The finasteride helps shrink the prostate. So that one doesn't really work quickly. That usually takes about 6 months to get the full benefit of the medication, just because the prostate's not going to shrink,
Right.
overnight. So so that's definitely one of the medications that I offer my patients. There are times though that the prostate might be so obstructing that even while on the medications, the patient might not be emptying their bladder all the way or might still have persisting symptoms. And if that's the case, then I would then do a workup to see, what kind of BPH surgery is right for them. So there are a number of different kinds of procedures that we can do for enlarged prostate, but depending on the size, the extent of the obstruction, there's different things that we look at that then help me figure out what is the best procedure that you would probably benefit from.
And I know I'm going to massacre this, but interstitial cystitis?
Yes.
Did I get that right?
Yes,
Wow.
interstitial cystitis, yes.
So what exactly is that?
So that is very common. It's most frequently seen in women. Not unheard of to see it in men as well, but the bladder is just very, it's inflamed in a way. It's some sort of inflammatory reaction, and a lot of times patients, this is the most common presentation, they think that they have recurrent UTIs, but every single time that they come in and get a urine culture while they're having symptoms, it's negative. It comes back as, oh, no, you don't have an infection. So it's very confusing to patients, like, why am I having these symptoms? It literally feels just like a UTI with the urgency, frequency, the pain, the pressure. And then once I kind of have those urine culture results, I kind of think, okay, this might be interstitial cystitis. So then I talk to them about their diet, their stress levels, which play a role in it as well. And that kind of helps me figure out, whether this is interstitial cystitis or if it's something else we need to dig a little deeper. But most of the time, the first line treatment for interstitial cystitis is just behavioral modifications and stress management. And a lot of times that does the trick.
Stress management.
So a lot of patients, everybody has a different way of presenting their stress and through their body. Some people might have IBS, some people might have migraines, and some people have interstitial cystitis. So it's very interesting, and a lot of times just the stress management tends to help.
Interesting.
Yeah.
You mentioned recurrent UTIs, and I know that's a common one too. What makes someone susceptible to having that happen over and over again?
So first I want to clarify what recurrent UTI is. So a recurrent UTI is a culture-proven UTI. So not just a urine sample, but a urine culture, the test that takes about 2 to 3 days to come back. So you have to have 2 proven urine culture UTIs within 6 months or 3 within a year. Then you're considered a recurrent UTI patient. And if that's the case, then we proceed with a workup as to why could this be going on. So we do a scan to look at your kidneys, look at your ureters, and then we also perform a cystoscopy to see if there's anything going on in the bladder or in the urethra. And there could be a number of reasons why somebody has a recurrent UTI. A few reasons could be stones. So there are certain stones that harbor bacteria that then present with recurrent UTIs. You can also have incomplete bladder emptying, whether it's because you have an enlarged prostate or you have a very floppy bladder. For over time, your bladder is not as strong as it used to. You're not emptying all the way. You can also have bladder stones. So there are some patients that have colonization of certain bacteria in their bladder that can one day turn into an active infection. And so that's usually patients that I would recommend being on prophylactic antibiotic, like a low dose antibiotic every day, or cranberry supplements. There's a number of other different supplements that we provide that help kind of keep those infections at bay. But yeah, those are just a few of the many reasons why somebody might have a UTI.
Well, there's so much going on down there. It's just
Yes.
there's a lot that can go wrong. Incontinence, I know that it seems to me that the awareness of incontinence and that it is treatable has grown in recent years.
Yes.
I mean, talk about a normal part of aging. A lot of people thought that it was that.
Yes.
And that tide is changing, thankfully. Tell me about the incontinence. Does it affect men and women equally? Does it seem to? What are the options for treating it?
Yeah, so there are a different number of incontinence. So there is urge incontinence, where the patient has that feeling of, I got to go to the bathroom right now, and then they try to get to the bathroom, and then they end up leaking just before getting to the bathroom. A lot of times that's because of overactive bladder. There's also stress incontinence. So stress incontinence is most commonly seen in women, I feel like, but there are times that men can have it too, especially if they've had some sort of prior urologic procedure. Most commonly, I see it after a male patient might have had a prostatectomy for prostate cancer. So you'll develop stress urinary incontinence because we're basically, once we take out the prostate, that muscle that you usually squeeze to hold your urine in, we're basically tearing it apart and putting it back together. And so it's going to be very weak at first. Usually within a year, it tends to get better with some physical therapy and a few exercises, but a lot of times it might not get better, and the patient's doesn't have the quality of life that they would hope for. And so at that point, then we would offer some sort of surgical intervention, whether it's a male sling or a artificial urethral sphincter. In women, it's most commonly seen as they get older after having childbirth and everything. There's also a mid-urethral sling we can place, aside from also doing pelvic floor physical therapy, which most patients would like to try first. So
A lot of these conditions that you talk about, it seems like a lot of the side effects or how they present themselves, a lot of them might be similar. So it's important to see a urologist to get a precise diagnosis on them.
correct.
How might bladder cancer present itself?
Most of the time, it's just blood in the urine, whether it's microscopic on a urinalysis or gross hematuria, meaning you can see the blood in the urine, even if it's just a one time. A lot of patients will say, this only happened to me one time. After that, I've been fine. I've been voiding just fine. But that's still a red flag to me. And so we always recommend, even if you have blood in the urine once with no evidence of a UTI or something at the time, then I would proceed with a workup, which would include, just like the recurrent UTI, getting contrasted imaging of your upper tracts, including your kidneys and your ureters, and then proceeding with a cystoscopy. So a lot of times patients, they question, why are we doing a cystoscopy if you already got a CT scan or an MRI? A lot of times bladder cancer is not easily seen on imaging unless it's pretty big. So that's why we recommend doing a cystoscopy, because a lot of times that's how we diagnose it.
And what is a cystoscopy?
It's basically a camera in the bladder.
Oh,
yes.
right. Okay.
Yes.
Yeah. And you can accurately detect it
Correct.
Yeah, okay.
Yeah, bladder cancer has a certain way, it has a certain appearance. And so I can't really tell whether it's low grade, high grade, or muscle invasive just by looking at it. That's why we recommend to go to the operating room and, take out the mass and see what it is. But just by looking at it, I can tell this patient, this is most likely bladder cancer. If somebody, let's say a patient comes in, they have asymptomatic blood in the urine, I perform their CT scan, everything looks fine, I perform their cystoscopy, there's a bladder mass. We end up going to the operating room, I'll resect it. So it's a minimally invasive procedure. I'm not having to cut or make an incision or anything. We go through the urethra into the bladder with a camera, and through that same camera, we are able to resect the tumor. I try and go deep enough where I get some of that muscle. That is the deepest layer of the bladder would be the muscle. So we want to make sure to try and get some of that in the specimen to see, is this tumor muscle invasive? Because if you have a low grade versus high grade versus muscle invasive tumor, all the treatments are different for each one of those categories. So.
Okay. And can bladder cancer spread elsewhere? Or?
It can, especially if it's gotten to the point of being muscle invasive. You're running at a risk of it spreading to first. Usually, it's your lymph nodes first, and then it could spread.
Let's talk about some myths surrounding bladder health. I hear about cranberry juice. Is that a myth that's good for bladder health?
So cranberry, it is good for bladder health. It helps prevent certain UTIs, most specifically patients that are prone to getting E. coli UTIs. It helps prevent adhesion of that bacteria to the bladder wall. So that's what the cranberry does. I personally don't recommend cranberry juice because a lot of times there's a lot of sugar.
Sugary, yeah.
And it kind of defeats the purpose. So I prefer to recommend cranberry supplements.
Oh, okay. Okay.
Yes.
Give me some other myth-busting topics. We didn't bust that myth. That myth turned out to be kind of true.
Yeah, and
cranberries are good for you.
They're good for you. It just doesn't cure all UTIs. So leakage, like we mentioned before, isn't just aging. You should definitely seek help if it's bothering you. I would definitely recommend seeking treatment for that. Don't overhydrate. So that can definitely also make you go to the bathroom more often, increase your symptoms. We want you to take a normal intake of fluid every day. Especially if you're passing a kidney stone, I definitely say more than 2 liters, but I would recommend daily about 1 to 2 liters for an average sized person. Yeah.
So even if you're not experiencing problems with bladder health, in terms of maintenance and keeping up your bladder health, what are some practical day-to-day advice that you have for people?
So I tell all my patients, practice timed voiding. That's going to the bathroom to void every 2 to 3 hours. Even if you don't have the urge, there's always going to be something in your bladder. Your kidneys are always making urine. So that kind of helps ensure that you are emptying your bladder throughout the day, not letting it get too full, that you're experiencing suprapubic pressure or all of a sudden urgency because you're so full. Also double voiding, which is when you go to the bathroom to void, when you're done, you wait 10 or 15 seconds and then try and void one more time. That allows the bladder, it just gives it a little bit of extra time to kind of come down a little bit and then help push anything left in the bladder. I also recommend making sure that you are voiding right before going to bed, limiting any fluid intake about 2 to 3 hours before bedtime. Of course, a lot of patients have to take medications at night, so it's okay if you can have a little bit of water with your medications. I just would not recommend taking an entire water bottle, for right before bedtime. And then also making sure that you're having good bowel movements. So having a good soft bowel movement every day is very important. And if that's not what you're having, then you can supplement your diet with either Miralax or Benefiber, anything that can kind of help sort of soften the stool. And the reason is because if you're experiencing constipation, that stool is sitting in the rectum and it kind of just starts taking up space that otherwise the bladder would use to fill up in the pelvis. And so you're just having to go more frequently to the bathroom, having more urgency. And so all of that plays a role because everything is so close together down in the pelvis. And the biggest thing is avoiding bladder irritants. So, and that's the most common thing I see. So avoiding things like alcohol, smoking, tea, sugary drinks.
Tea.
Tea. Yes.
I love tea.
I know. I feel like everybody here loves tea.
It's the South.
Yeah.
So what about unsweet tea?
Nope. Still tea.
Oh,
There's
come
something
on.
in the tea that causes irritation. Also, any carbonated drinks like soda or carbonated water, spicy foods, anything acidic, spicy, or with food coloring, all of that can irritate the bladder. Not everybody is irritated by the same things. So I actually recommend my patients with either overactive bladder or interstitial cystitis to have an elimination diet. So for about 1 to 2 weeks, eliminate anything that is considered a bladder irritant, see what your symptoms do, and then slowly add what you normally eat one by one and see, okay, I noticed that after I drank orange juice this morning, I started having more urgency and frequency. And so you can kind of tell what irritates you.
You were awesome. Thank you so much for being here and informing us on these issues. And I encourage everyone out there to schedule an appointment with you.
Of course, yeah. I'm happy and available, and I'm just excited to meet more patients and establish a relationship with them. It's been great so far. I just started just a few months ago, and I'm so excited for what the future has to hold.
For more information and to schedule an appointment with Dr. Nieves, call 863-680-7300 or visit watsonclinic.com/Nieves. And don't forget to subscribe and leave a review for us wherever you get your podcasts. Thanks for listening.